You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 26, 2018. This week, a huge reversal in oxygen therapy, evolocumab, troponin testing, cardiotoxicity of cancer drugs, and Joint Commission accreditation. Medicine is so damn humbling. For decades, I've been oxygen's biggest supporter. I just couldn't imagine that less is more also applied to oxygen supplementation. But just this week, a pulmonologist pulled me aside and asked, Mandrola, can you help me convince my colleagues to stop using so much oxygen? And I'm thinking I misheard him. I'm like, what? Oxygen? More of that has to be better. He's like, I thought you were the professor around here. Don't you read The Lancet? Well, it turns out I had missed a shocking systematic review and meta-analysis looking at liberal versus conservative oxygen therapy in critically ill patients. Once again, the McMaster's team comes through with excellent research. Their search of the literature revealed 25 RCTs, randomized controlled trials, that enrolled greater than 16,000 patients with serious critical illness like sepsis, stroke, trauma, MI, emergency surgeries, basically any patient admitted to the ICU. They excluded studies of patients with chronic lung disease, patients with psychiatric disease, patients on ECMO, and those with elective surgeries, and sit down for the results. Compared with the conservative strategy of O2 use, liberal oxygen strategy associated with an increased risk of in-hospital mortality, the relative risk ratio 1.21 and the confidence intervals 1.03 to 1.43. The heterogeneity of the funnel plot was low, which increases our confidence. And meta-regressions of the trials found a dose-response relationship. Now, studies that had increased oxygen saturation had an association with higher mortality. Now, some good news was that the risk of hyperoxemia seemed to wane over time, with the relative rate for higher mortality at 30 days was 1.14, and at the longest follow-up, only 1.10. Editorialist Dr. John McEvoy from Johns Hopkins lauded the study's methods and explained in his editorial how excess oxygen supplementation could plausibly be detrimental. This, my friends, has to be one of the top 10 studies of the year. Though I am humbled about being wrong, I must say I love medical reversals. They add such intrigue to the practice of medicine. The authors of the review point out that questions remain as to the optimum range of oxygen saturation that minimizes the risk of hypo and hyperoxemia in acutely ill patients. Mainly, they point out that there is a risk of hyperoxemia. And further, the BMJ incorporated this evidence and other studies into one of their rapid communications practice guidelines. And I must say these rapid communication documents are excellent. The second topic today is on evolocumab. Amgen makes evolocumab, and this week the company announced that it is lowering the cost of the PCSK9 drug by 60%. It's going from $14,000 per year to about $6,000 per year. Estimates have this price lowering out-of-pocket costs for U.S. Medicare beneficiaries down to somewhere between $25 to $150 per month. Before the price cut, Amgen said that 3 of 4 patients started on the drug eventually abandoned it, likely due to cost. Recall that the FDA approved evolocumab on the basis of the Fourier trial, and this was a 27,000 patient strong RCT that reported evolocumab added on a background of statin therapy reduced the risk of a composite primary endpoint by a mere 1.5%. Importantly, non-fatal events drove the primary endpoint, and actually, CV deaths and overall mortality were numerically higher, although not statistically higher, in the evolocumab group. Essentially, no mortality reduction with this drug. So I would argue that at nearly $6,000 per year, the drug still is on the flat part of the curve, e.g., it's a low-value intervention. One interesting political point is that the announcement came as the White House was calling for greater transparency and lower drug prices, and the President of the U.S. was scheduled to appear at the Department of Health and Human Services. Another thought is this. I've always wondered why the professional societies weren't more vigorously pressuring the PCSK9 makers to do this from the outset, meaning to lower the prices from the outset. Third topic is about ruling out myocardial infarction quickly. Now, at ESC a couple of months ago, Scottish investigators in the High-STX trial reported that hospitals that incorporated high-sensitivity troponin testing over contemporary troponin testing did not experience lower rates of MI or CV deaths. But recently, this week, New Zealand investigators published a preliminary report in JAMA Cardiology, and they were looking at a novel point-of-care troponin test that can be done in 15 minutes. They can't yet officially call it a high-sensitivity troponin test, but it is a rapid point-of-care test. And they asked the question, could this rapid test reliably rule out myocardial infarction? Now, this is a somewhat different question than that was asked in the High-STX trial. The new test, it's called the iStat Troponin I-NX, and it's by Abbott, and it was used in 354 patients presenting with chest pain. And in this observational study, all of these patients got the point-of-care test and the standard high-sensitivity troponin assay that goes to the lab and takes 60 minutes. So all patients got the two tests. The point-of-care test identified a little more than half, 56% of the patients as low risk, with a sensitivity of 100% and, importantly, a negative predictive value of 100%, which was essentially equal to the standard assay. Now, I like this study. The authors used very cautious words in the conclusion, and they wrote a very clear paragraph on the limitations of this brief, early study. And chief among my concerns is that only 24% of the patients in this study presented in under 3 hours, and the median time to testing was 4.5 hours. So the question is, would the same negative predictive value hold up in patients who present earlier? The authors say further data is needed on the time from symptom onset function of the test. Yet I report on this early study because the advantage of a 15-minute test to rule out MI is obvious. What if this could be done in ambulances? You could have patients ruled out by the time they get here. This also might have great use in outpatient chest pain centers, and it might reduce the amount of patients referred for further stress testing and workup. And I look forward to hearing more about this topic. Next topic is about cardiotoxicity of cancer drugs, and my friend Vinay Prasad, he's an oncologist and perhaps the world's best critical appraiser of medical evidence, has induced me to learn more oncology. Vinay has a podcast and he reviews an oncology paper of the week. And this, plus the fact that more and more of my patients get cancer therapies, has increased my awareness of two things. One is that there is a lot of hype in oncology, and two, cardiac complications of cancer therapy are on the rise. Journalist Will Boggs has a nice piece on the cardiotoxicity of angiogenesis inhibitors, the tyrosine kinase blockers that target endothelial growth factor receptor. These drugs are mostly used for solid tumors like renal cell, metastatic colon CA, non-small cell lung cancer, etc. The cardiac complications include acute rises in blood pressure, left ventricular dysfunction, QT prolongation, and myocardial ischemia. Now, it seems obvious, but cardiologists are going to have to embrace the idea of lifelong learning and become more familiar with the field of cardio-oncology. So in that vein, I actually went searching and I found the 2018 review article on angiogenesis inhibitors, and it was a bit sobering. One of the quotes in the conclusions was that, quote, the benefits are limited and predictive biomarkers for this class of agent remain elusive. Now, you don't have to listen and read Vinay for very long to learn to be skeptical about the benefits of many new chemo agents. And the medical student in my mind often wonders how we help patients with cancer by using drugs with significant cardiotoxicity that may have only marginal actions against cancer. And one of the quotes from the news coverage included a comment that an informed cardiologist should be seen as a fundamental minimum component for optimal cancer care. So, okay, I have set as a goal to learn more oncology. Final topic, I think, is a super important one, Joint Commission accreditation of hospitals. The mission statement for the Joint Commission from their website states that they aim to improve patients' health. Now, helping people is also the main thing that drives people who work in hospitals, doctors and nurses and administrators. And a group of researchers from Harvard, led by Dr. Ashish Jha, set out to answer the question, does the Joint Commission fulfill its mission? The BMJ published their large observational study of more than 4 million admissions for 15 common medical conditions and 6 surgical procedures. The primary outcome was mortality, 30-day readmissions, and patient satisfaction. These are notable because mortality is the most important quality outcome, obviously. After looking at data from thousands of hospitals, some of these hospitals accredited by Joint Commission, some by non-Joint Commission entities, and others by simply state survey agencies, the authors found no significant difference in mortality in Joint Commission versus non-Joint Commission accredited hospitals. And what's more, patient satisfaction scores were mostly not statistically different, but when they were different, they favored non-Joint Commission hospitals. My friends, these are important observations. Yes, they are observational and they deserve confirmation. But the key message is that policy choices should be guided by evidence just like treatment choices are. In fact, it may be more important to use evidence for policy because policy may affect more people than a specific medical intervention or treatment. The cost of Joint Commission is also relevant. Hospitals spend big dollars to get through a Joint Commission accreditation. But if the Joint Commission does not improve mortality or readmissions or patient satisfaction, how can it justify this high cost? I mean, given the disparities of care in the U.S., forcing struggling hospitals to pay fees to rent-seeking organizations is outrageous. And the final and most important reason to require policy to pass muster in an RCT is the possibility that the policy causes harm. Now, there's a strong argument out there that Joint Commission's strong endorsement and enforcement of the pain as a fifth vital sign contributed to the opioid crisis. So, in summary, since clinicians use evidence, so should policymakers. And when evidence shows a pill or surgery doesn't help people, we de-adopt it. The same goes for policies like requiring Joint Commission branded accreditation. So that's it for this week in cardiology. I'm grateful that you listened, and if you enjoy this podcast, please consider subscribing and rating it on whatever app you get it from. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.